Thank you, Phil, Steve, all the panelists. Honored to present here. This is a work that the Guidelines Committee put together. I do have some involvements, but none of them are pertinent to this discussion. First, just a little background. What is the SAGES Guidelines Committee? And what are our guidelines? Who creates them? Why do they exist? What are they? Where are they? How are they to be used? So the Guidelines Committee is a group of about 36 members of the Society. And it spans from people who have been members of the Society for a very long period of time, like me, and goes to people who are new members to the Society. And these guidelines started out as 1 or 2 or sometimes 3 paragraph comments and position statements, and now they've evolved into complete evidence-based reviews of various procedures, disease entities, techniques, things like this, that are published in Surgical Endoscopy and on the SAGES website. They can be found at sages.org under the Publications tab very easily. These are reviews that are intended to be used to help guide clinical practice. They're not the be-all and end-all. They are the guardrails. And for most people, we expect that their care will fall underneath these guidelines, but certainly there's exceptions. And they're not a mandate that this is how care is done. They're a reference for surgeons who are providing clinical care to their patients. We use the grade system to analyze literature. It's an involved system that I think many of the professional societies that issue guidelines utilize. It isn't something I can cover in the next 10 minutes, but it is an effective way of looking at a body of literature and coming up with a strength of recommendation based on the overall contributions of literature rather than relying on individual pieces. There are 4 levels of evidence that are assigned to individual works and to the body, and then there are two recommendations, strong or weak. And basically strong recommendations mean that there's a very unlikely chance that any further good quality evidence would change our mind about something. And a weak recommendation is that another good quality contribution to the literature very likely could change our mind on that as well. So this is, I don't know if it needs to be clicked. Anyway, well, that was going to be my attempt at humor for the talk. You know, it's a lot of dry material in this presentation, so I thought SAGES is a procedure-oriented society, and we show videos. I was going to show me typing, and that's the procedure we use for issuing guidelines. But what we really try and do is to define and ask good questions. And the way a guideline is constructed is to do an initial literature search just to get a feel for what's out there, what the scope of the published literature is, and then to use the PICO process to ask good questions, looking at populations, interventions, comparisons, and outcomes, and then revise our questions through group discussion, assign a small task force of 2, 3, or 4 members to evaluate and begin writing on the topic, and to do a more focused final literature search that really goes through, looks at the results of database searches, and then reviews the references of pertinent high-quality articles to make sure that we haven't missed any references that we should include. For this particular guideline on new techniques and technology, there are some definitions that are important. Technology we use synonymously with the device, and technique is synonymously used with procedure. So a modified device would be something that's existing, something you're familiar with. The example given here is a stapler with a new handle on it. A new device would be a disruptive technology, or something that the surgeon hasn't used before, something that we're not all familiar with. A modified procedure, similarly, would be performing an open appendectomy and then converting to a laparoscopic appendectomy as what you offer in your practice. Or a new procedure would be something entirely different, and POEM seems to be a good example for that. So what are the recommendations that are in this guideline that will show up in those sources that I identified once it's published in the next few months? Guideline number 1 is that surgical societies should be the house that provides assessment of new technology and techniques. It should be done in a timely fashion so that we can guide decision-making among surgeons and hopefully insurers, payers, and the like. Guideline 2 is split into two recommendations. A is that surgeons who are considering introducing new technologies and techniques into their practice should have training that's specific to that, to decrease the learning curve and related complications. That's important in improving patient safety. And the B section of that is that the necessary training steps depend on the degree of novelty or change that's introduced by that technique or that technology. This needs to be reviewed prior to introducing that technique or technology into one's practice. The third recommendation is that institutions and experience centers and specialty societies play a major role, as does industry. It really is experienced centers and specialty professional societies that have the primary responsibility for training new procedures. And industry's role really should be a limited one. Number 4 is that surgeons who are planning to introduce a new device or a procedure in their practice should have completed relevant surgical training for that particular procedure or device. And of course, they should possess privileges and expertise in the underlying treatments that traditionally have been offered. Recommendation 5 has to do with minor modifications. This is the perfect opportunity to perform self-assessment and to track one's own personal outcomes through various clinical databases, registries, and the like, so that the surgeon and the institution are able to evaluate the progress of the introduction of this new technique or technology. A lot of writing on this one. Guideline 6 basically is about patient protection. Calls for high levels of professionalism, regular self-assessment and self-regulation, and using great caution in introducing novel techniques in a way that allows them to be studied and evaluated for safety and efficacy on an ongoing basis. And number 7 recommends that basically comparative effectiveness should be analyzed. Costs, patient outcomes, safety profiles should always be assessed before introducing a new technique or technology and after their introduction so that we can learn about the device and make sure that we're achieving best practices. Summarizing the last 2 slides, and that is this slide basically summarizes and says what this guideline tells us. It tells us that SAGES will continue to guide the world of surgery through its technology and value assessments and through its guidelines, 2 very effective and crucial committees. That patient safety is our first priority, and the introduction of devices and techniques are going to require education and familiarity, best based in professional societies and expert centers. The steps required and the intensity level should be based on the magnitude of change. Experience centers and professional societies are going to play a major role in this process, and rightfully so, and industry participation should be minimized. It's especially useful when there are new and modified devices introduced, but otherwise, professional society should have the major role in this. Surgeons are responsible for their own education for IRB approvals when necessary, and disclosing conflicts of interest to patients and informing them as they obtain consent to perform new procedures or introduce new technologies. And comparative effectiveness and cost and utility studies should be part of any introduction of a new technique or technology. What this guideline doesn't say is that we can't partner with industry to advance patient care. However, every approach has to be a responsible patient-first approach. It shouldn't be the application of an existing device, for example, in a place where it just doesn't make sense. Novel techniques and technologies cannot or should not be introduced. We're not saying that. What we're saying is that the view toward value is critical, and these need to be evaluated both before deployment and afterward in an organized fashion. And we're also not saying that the process of introducing new techniques and technologies should be an onerous one. Actually, it should be scalable and flexible so that minor modification can be accommodated into practice very easily, and disruptive technologies can be introduced safely. That's my conclusion.